Hi, my name is John Preston. I'm a professor of psychology at Alliant International University, and it's my pleasure to be able to present this video on understanding and managing treating depression. Before we get started, I should mention that I'm a clinical psychologist, and I've taught graduate school and medical school for 36 years. And during the last 20 years, I've done a lot of private practice doing second opinion consultations for people that have had treatment, but it doesn't work very well. They only have partial recovery. So we're going to be dividing this talk into three parts. And part one is understanding depression and the symptoms of depression. There's also going to be a quiz that you or a family member can take to determine if you have the symptoms of clinical depression. Part two, the 5 most common mistakes made in the treatment of depression. Lots of people get treatment but only have partial responses to that, and we're going to try to really identify very specifically what problems occur and how to fix that. And then finally will be keys to success, and these are the things that really are going to make it or break it in terms of success in treating depression. So thanks for listening, and let's get started with part one. 15% of people in the United States sooner or later are going to suffer from very severe major depression, also referred to often as clinical depression. And although almost every human being will experience grief or times of mild depressions in response to life circumstances, we're talking here about depressions that are so severe that it really significantly interferes with a person's ability to function at work, school, and also in family and social relationships. The suffering of depression is very significant, and in part because most depressions are recurrent. That is, most people do not have just one episode, but may go on to have additional episodes. The bad news here is only about half of people in the United States actually get treatment for depression. And so what happens is they grit their teeth and suffer through this. That's not necessary. There are good treatments that are available, but that's the current state of affairs. Also, and we'll talk about this being a problem. Most people in the United States that are treated for depression are receiving antidepressant medications, but that's it. They're not getting psychotherapy or other treatments. Antidepressant medications, when appropriately prescribed, can be a lifesaver and do play a big role in treating especially really severe depressions. But as I'm going to strongly suggest, medications alone are not enough, and there's data to support that. In the United States currently, you may be surprised to know this, 21% of Americans are taking some kind of psychiatric medication, and yet only 3% of people in the United States are in psychotherapy. Now this is regarding all kinds of psychological and psychiatric disorders. So by and large, most of these psychiatric disorders are being treated solely with medication. It's a little bit different with depression, but as you can see that people currently treated for major depression, 75% of these people are treated with medications alone, and only 43% get psychotherapy. Once again, we're going to argue that the combination of the two oftentimes is much more successful. The medication treatment for depression in the United States is occurring largely in primary care medical settings, where about 85% of prescriptions for antidepressants are given out by primary care doctors and nurses. And unfortunately, the success rate in full recovery on medication treatment alone in primary care medical settings is somewhere around 35%, which doesn't sound very good. This is not a criticism at all of primary care providers or even the antidepressants, but it's really, I want to highlight that in primary care, you just do not have, physicians don't have enough time to do a very careful and comprehensive evaluation. Oftentimes these medical appointments range from 10 to maybe 15 minutes. That's not nearly enough time to get the adequate kind of history and background and evaluation. And then the biggest problem of all is follow-up. When people are experiencing severe depression and they're in treatment, they need to be talking to or seeing a therapist or the prescribing doctor at least once a week. In other countries, in Canada for instance, that is the standard of practice, and that's really the way to go. But in the United States, unfortunately, often after a very brief evaluation, the physician gives an antidepressant prescription and says, I'll see you in a month. If you have problems, give me a call. This is probably largely the reason that we have this 35% success rate. There are ways to do this that are better, and the success can be significantly beyond 35%. Most cases of depression respond well to integrative professional treatment. What do I mean by integrative treatment? Psychotherapy, clearly a lot of research support for therapy. There are various kinds of therapies that have been developed specifically for treating depression. And when you're seeking out a therapist, it's going to be important to ask them if they have training and experience in providing therapy specifically designed to treat severe depressive disorders. Also critical are lifestyle changes. We're going to be taking a look at some of that today in the video. Treating underlying medical problems. About 10% of people that have significant psychological symptoms, it's actually caused by an underlying medical condition. And in about 80% of the cases, people don't know that they have the condition because it's mainly showing up with emotional symptoms and behavioral symptoms instead of physical symptoms. So we're going to talk about that. Exercise is enormously important in treating depression. The research strongly suggests that exercise treatment can treat depression. But I'm sure, as all of you know, when people are depressed, it's very, very difficult to actually follow through with doing exercise. The person who's depressed may certainly understand that this could be an important part of treatment, but when it comes to actually doing it, it's very hard to do. I think largely this is because of a couple of things. One, many times with depression, there's such fatigue and lethargy, it's just hard to kind of get up and get moving. That's part of it. But the other thing, too, is pessimism. And this is just a symptom of depression. The person may say, well, it's not going to help me, that sort of thing. So when we talk about exercise, then this is not going to be practical for any person really who's depressed unless they can actually go out, take a walk, get to the gym or something. And almost always that requires the support of a coach. And the best coach in the world is your best friend or your partner or your spouse, or if you're a parent of an adolescent who's experiencing depression. Combating social withdrawal. One of the most effective treatments for depression is to use approaches to prevent the depressed person from unplugging from life. This is seen almost across the board with depression, is that when people are hit by major depression, they stop doing stuff. They stop going out with their friends. They don't go for a ride in the country. They cancel vacation plans. They don't go to church. They don't go to bowling. And on and on. And what's been shown is that this is a significant factor in increasing the severity of depression, but also combating this, and that is putting in place some ways to reduce withdrawal, is one of the most potent treatments for depression, which we'll be talking about as well. And then finally, antidepressants are helpful for many people with depression, but not everyone. It's just when they're indicated. So let's talk about depression, what this is. Severe depression, major depression, also known as clinical depression, they're basically all the same. These are the terms that are used in psychiatry and in medicine. And by definition, in the diagnostic criteria, they say that you have to have a period of at least 2 weeks of depression, severe depression, for it to be honest to goodness depression. The truth is, the majority of people that have severe depression, it lasts way beyond 2 weeks. We're looking at the average depressive episode lasting between 9 and 12 months. Many people after this prolonged period of time without treatment will begin to come out of the depression, but only after many, many months of suffering. And obviously that's what we want to focus on, is trying to reduce the amount of time people have to experience the suffering, and that's what treatment's all about. Depressive symptoms. This is going to be important for me to mention. The obvious is that when people are very depressed, they're going to say, I'm sad or I'm depressed, and they're going to look sad and they're going to look depressed. And the people around them, the people that love them, will be able to just look at their posture, their facial expressions, what they're actually saying about feeling pessimism and hopelessness and tearfulness and that kind of stuff. So it'll be pretty obvious. But at least a third of people that have severe depression actually don't really look or feel sad. And what we see here is common. About a third of people with major depression, the main change of mood is not depression or sadness, but it's irritability and low frustration tolerance. And so here's the person who outwardly does not look clinically depressed. And so many of their friends and colleagues and primary care doctors and so forth would not think the person's depressed. However, this is a person that comes home from work, and let's say it's a guy and he comes in and he's slamming the door, and yelling at the dog and the kids and that kind of stuff. And many times, friends and loved ones will think, well, this guy's just, he's just overwhelmed, or this guy has an anger management problem or something like that, when in fact he may be suffering from major clinical depression. So we can't always look at the mood state and absolutely conclude that it's true major depression. Loss of interest in normal activities. That's what I was talking about a few minutes ago. And this is seen really almost across the board where people stop doing things. And finally, for this to be severe depression, it has to interfere with functioning. There are a lot of people who have mild depression, and it's unpleasant, absolutely, but they function well. They pay their bills on time, they get to work on time, they don't abuse sick leave. But with severe depression, it can be so debilitating that despite a person's best efforts, they have a lot of difficulty in being able to function in occupational settings, and then also in school, if they're a college student, for instance, or in social relationships and being a parent as well. Other symptoms I'm going to mention very briefly are sleep problems. And although some people that have depression have trouble falling asleep, the biggest problem you see with depression is problems staying asleep. So people that are depressed many times go to sleep, but they wake up real frequently, tossing and turning during the nighttime. And you can imagine that's not going to result in very good quality sleep. The other thing that happens is something called early morning awakening. And this is where people who are experiencing depression will just wake up maybe at 4:30 in the morning, and they can't go back to sleep. And they may just lie there, staring at the alarm clock and saying, "I wish I could go back to sleep." This is due largely to some of the hormonal changes that occur with depression, and causes this to happen. It's enormously frustrating for people, in large part because many people who have early morning awakening or this tossing and turning all during the night are really exhausted during the daytime, so it makes things a lot more difficult. Appetite changes can go in one of two directions. There are some people that gain a lot of weight when they're depressed. But conversely, there are some people that lose a lot of weight. Especially common in elders is a significant weight loss. So this is a sign to be on the lookout for. Loss of sex drive, self-explanatory, fatigue, and decreased vitality. And one person said at some point that the opposite of depression is not happiness. The opposite of depression is feeling alive. And that's what we're talking about here, a sense of vitality that just seems to evaporate when people are in clinical depression. So at this point, what I want you to know is that on this particular website, you can access a depression quiz. And this could be used for yourself if you're depressed, or if you're listening to this program because you're concerned about a family member, they also could take this quiz to identify two things. One, is this really clinical depression? But also to get really specific about what some of the signs and symptoms are. And this is going to, I think, be helpful as people then make decisions about getting treatment. Okay, part 2, making the most of treatment for depression. And we're going to talk about that in part 2 and part 3. And the first thing I want to cover are the 5 biggest mistakes that are common that account for partial recoveries or failure to really respond to treatment. It's unfortunate. There are many people that are suffering enormously and they seek out treatment, and yet they only get a partial response, whether it's medications or psychotherapy. And so all people that are in treatment and their family members, it's important for them to know some of the stumbling blocks here. Okay, first, the diagnosis is wrong. There are 2 conditions in particular that oftentimes are diagnosed as depression, but they're really not generic garden variety major depression. Let's take a look at these, okay? The first is bipolar disorder. With bipolar disorder, it used to be called manic depressive illness. I think most people know that there are not only depressions, but there are manic episodes as well. And the manic episodes in bipolar 1 were this extreme agitation, impulsivity, rapid speech, very poor judgment, decreased need for sleep, and sometimes in very intense anger, rage, and severe restlessness. Those are manic episodes. Now, when people can also suffer from a disorder called bipolar 2, where there are episodes of severe depression, but then they have more minor manic episodes referred to as hypomania. And here, this is really something most people don't mind. They feel more energized, more upbeat. They also oftentimes don't need to sleep as much as usual. They have a lot of energy, a lot of good energy. Typically, these hypomanic episodes last only a matter of 3, 4, or 5 days, and then they go away. So they're very, very short duration. Now, the reason I'm mentioning this is that the depressions that you have with bipolar disorder share a lot of symptoms with the more common version of depression that we've been talking about. Low self-esteem and appetite changes, sleep changes, loss of sex drive, and so forth. However, it's important to make a distinction between bipolar disorder and more common clinical depression. The reasons are mainly that the treatments for bipolar depression are very different. And when there's a misdiagnosis, if somebody comes in to see your primary care doctor or psychotherapist and they are in a depression, but in fact they have bipolar disorder, the use of certain antidepressant medications has been shown to, most of the time it's just ineffective, but oftentimes it can actually make the disorder more severe over a period of time. So this is going to be very important for the person that is being evaluated to go to somebody who has experience in treating and assessing depression, to make a distinction between ordinary depression, clinical depression, and the depressions that you see with bipolar disorder. And I've included some slides here that mention some of the basic symptoms. We will be providing you with a list of these symptoms on the website. After you see the video, if you want to access that, then you'll be able to review that. Okay. The second is grief. And grief may be the most painful experience that many human beings will ever experience, the loss of a loved one. But it's really important to emphasize that grief is not pathological. Grief is not mental illness, despite the intensity of the emotional suffering. Now, the truth is that when people in the United States, when people lose a loved one, about 20% of these people, maybe as high as 25%, it will start off as grief, but it will disintegrate into, within a few months or 6 months or maybe a year, into severe depression. So grief can turn into depression. But for most people, it's not depression, it's grief. Good grief. Let's talk about this just a little bit. Grief, we have, the normal feelings associated with that: sadness, loneliness, and so forth. But for most people that are experiencing these very painful emotions, these feelings make absolutely perfect sense. They've lost somebody that matters to them deeply, and so it's not like it's not that I feel this is abnormal or crazy. This is what happens when people lose a loved one. Grief also oftentimes lasts a long time, and I want to talk for a minute about this because in our culture, I think we really have a kind of get on with your life kind of mentality, where everyone rallies around the person who's had a loss at the time of the loss and provide appropriate love and compassion and support and sympathy. But oftentimes after 6 months or maybe by a year, there's this expectation that people should sort of be over it. But the research does not show that. Now, people walk down this path of grief in very different ways. There are people that within a few months, the grief begins to subside in intensity. But the majority of people continue to have significant grief that will last anywhere from 2 to 3 to 4 years, and sometimes beyond that, depending on the nature of the relationship. For instance, if you lost a child, then grief can go on for a decade or more. But it's really important to emphasize that grief, unlike depression, the feelings of grief tend to come in waves. Where with depression, people may feel largely downhearted, despondent, sad, pessimistic, and hopeless most of the time. With grief, at some point, it doesn't really permeate all of a person's life. There will be times when a person who's lost a loved one will be able to have some distance from their suffering, and they will be able to enjoy having lunch with a friend, or watching their grandchildren play, or enjoy a funny TV show or a movie, look at a beautiful sunset. However, there are going to be things that happen, there will be reminders of their loss, and that's when people get hit with this wave of grief. Now, the reason I'm going on about this is that, again, I think there's a social expectation that people should kind of be over it. I don't like that term at all. I think it's inappropriate, but to have resolved their grief in a year or thereabouts. But the actual majority of people, this lasts for a long time. And when a person is grieving and it continues for months and months and months, and maybe for years, they may conclude, or their family may conclude, that this is a mental health problem. This is a psychiatric disorder, this is depression. We've got to keep in mind that normal grief, unfortunately for many people, lasts a long time. Now, with social support and facing the loss and mourning the loss, thank goodness what happens over a period of time is the frequency and the intensity of these emotional waves of loneliness and sadness are less prominent, and a person begins to get back to a place where they feel like they are resuming a normal life. But oftentimes, as I mentioned before, that takes a long time. How can you tell if somebody has depression or if it's just really severe grief? And here are some guidelines, okay? The first thing is, how does the person feel about themselves? Almost always across the board, when people are depressed, for whatever cause, people's self-esteem really declines. A loss of self-confidence, they start to feel worthless, and it's just a key symptom that you see in depression. With grief, self-esteem is really not affected that much. So let's say we have a man who's lost his wife, and he's going through a period of very severe grief and suffering a lot, okay? If you were to ask him, how do you feel about yourself? He would likely say, well, I mean, I feel fine about myself. I'm a decent person, but God, I just miss my wife so much. So this is a very important question. Family members can ask this as well, you know, but also for psychiatrists, physicians, mental health therapists. This is a very important question to try to make a distinction between severe grief and depression. Suicidal ideas are rare in people who have grief, although they may occur with depression. Extreme agitation, a complete inability to function, and a complete lack of any positive emotions, where this negativity just is pervasive. That's what you see with depression. So this is helpful in distinguishing grief from depression. With grief, psychotherapy and counseling can be very helpful, although in our country, many people are able to navigate through this time in their life by the support of their friends and their family and possibly their clergy. One good reason for getting psychotherapy for people that are going through grief is if they don't have a person in their life who really is available to listen to them over a longer period of time about their suffering. And this is, you know, over the years I've seen a number of people in therapy who don't have clinical depression. They have normal grief, but they come for several months because they really need to be able to talk openly about something that's very painful, and it may be hard for their family members to hear that. Okay. Number two, depression can be caused by an underlying medical condition. And here's the problem with this, is that I alluded to this before. There's certain conditions we'll talk about very briefly that can go on for months or years and never be identified, and yet they're causing the depression, or they're making treatment more difficult. Okay, so let's take a look here. We're going to be taking a look at as it says, the slide says the three most common problems, and now I have 4 items up here, so obviously that's a mistake. But we're going to take a look at mild hypothyroid, primary sleep disorders, chronic pain, and also some changes in female hormones can be responsible for mood changes. These are the most common kinds of medical problems that might provoke depression. I want to spend a little bit of time on this simply because it is so common as a cause of depression, and this is very subtle. Mild hypothyroid. Severe hypothyroid condition is easily identified by a number of symptoms such as enormous fatigue, weight gain, dry skin, constipation, hair loss, as well as some depressive feelings and that sort of thing. But this version of hypothyroid really doesn't have those particular physical symptoms and presents mainly as changes in mood in some individuals. Now, as the slide says, 10% of all depressions, turns out, is because of this subtle, sometimes called subclinical hypothyroid condition. And yet, if people don't know they're sick, then they will assume that I'm depressed for other reasons. They'll go and see a therapist, and the therapist may say, why do you think you're depressed? And they may say, well, I've been in this lousy job for a long time, maybe it's really getting to me. People try to make sense out of their experiences, and a lot of, probably everybody has some things we can point to their source of emotional difficulty, if not suffering. But it's going to be really important for every single person who is depressed to get their thyroid checked. Many times what happens is there are situations in a person's life that provoke depression. This could be the loss of a business, a relative getting a severe medical illness, for instance, or death of a loved one, or other kinds of psychological stresses. So it may be that these psychological factors are the main thing that has sparked the depression, but if they also have an underlying and unidentified subtle thyroid problem, then standard treatments like psychotherapy and antidepressant medications oftentimes are not going to respond the way they're supposed to. The thyroid gland plays a big role in the amount of energy that people feel and overall general metabolism. And it's going to be important then for any person with depression, this is not true for children, but for teenagers and for adults, to get this particular test. And it's a thyroid test. It's for TSH. It stands for thyroid stimulating hormone. This is routinely done in all yearly physical evaluations by primary care doctors. And if someone's depressed, they should request a thyroid screening, and then it becomes much more easy to identify. The normal TSH ranges from 0.3 to 3.0. However, there are many people that have severe depression where they have a TSH value of 2.7 or 2.5, technically in the normal range, but that actually in a depressed person can be contributing to the depression. And so what we've included is a hypothyroid fact sheet, which is available on this website to give you more detailed information about this and also to share with your primary care physician. There are many primary care physicians that may not be aware of the role of this very subtle thyroid disease in depression. And when people have this kind of thyroid condition, treating with tiny doses of thyroid replacement hormone can make a huge difference. So this should never be overlooked. Okay. I'm skipping a few of these things. Primary sleep disorders. Once again, we're going to talk about two sleep disorders that occur very frequently, but may go unnoticed literally for years. And because they occur when the person's asleep and that individual may not even know they have the problem. Both of these can cause significant daytime fatigue. I mean, they always cause daytime fatigue and can cause severe depression or make depression worse. But you got to identify them. And once these are identified, they can be treated. Okay, so primary sleep disorders, let's take a minute or two and talk about this. The first is obstructive sleep apnea. And look at the prevalence rate for this. 24% of males and 10% of females in our country will have some version, mild, moderate to severe sleep apnea. And once again, this can go on for a prolonged period of time and cause enormous problems with functioning. Sleep apnea, obstructive sleep apnea, is where a person's airway collapses when they're going to sleep. And at some point, then they have to draw air through the collapsed airway. You can see here on the diagram on the top is a normal open airway. With obstructive sleep apnea, the airway collapses and they can't breathe. And within 15 to 20 seconds, the oxygen levels in blood go so low that it causes the person to reflexively gasp and with great force draw air through the collapsed airway, and then they're okay for another 15 or 20 seconds, and then they do it again. So a person who has obstructive sleep apnea can have between 200 and 400 of these episodes of gasping during the nighttime, and it's impossible to ignore this. If you were sleeping with this person, it would be so obvious. But here's the story, and that is a lot of people who have a spouse or partner that they're sleeping with that have sleep apnea, many people pretty quickly just tune it out. They habituate to it. They don't even notice that. There are a lot of individuals who the wife will say, "Hey, honey, you're making these weird noises during the nighttime. You need to go see your doctor." And that's when that gets diagnosed very easily. But it's when the bed partner is really unaware because they're tuning this out. So this is something we should always evaluate if you have depression and daytime fatigue. Take a look at this. Obstructive sleep apnea. In 40% of people, it causes depression alone. I mean, it is a sole cause of depression, and plus, as we said before, these medical conditions can aggravate depression that are caused by other causes. Restless legs is the other primary sleep disorder where the restless legs go unnoticed by the patient, but they interfere with people being able to get into deep sleep. And the result is here, about 40% eventually will develop severe depression simply as a consequence of having restless legs, which once identified can be treated. And by the way, a common problem that causes or aggravates restless legs is overuse of caffeine, but there also are medical treatments for restless leg syndrome. Chronic pain, 15% of people around the world eventually are going to have to live with chronic pain. Having severe pain in itself is depressing. It interferes with the ability to do normal things in life, and it really can interfere with sleep. So obviously, this is something people are very much aware of, and this needs to be taken seriously and treated. And then also, very briefly, there are some women that are very sensitive to having mood changes associated with different phases of their menstrual cycle and different reproductive times in their life, such as premenstrual depression and postpartum depression. And here, it's the hormonal fluctuations largely that play a role in provoking depressions. And the person really should be treated medically and by somebody who is really familiar with this kind of mood disorder. Next, sleep disturbances. This may be one of the most common reasons that people do not get better with standard treatment. 30-second discussion about stages of sleep. Probably everybody has seen a chart like this in their high school psychology book or Psych 101 or something like that. But all human beings go through different stages of sleep during the night. And stages 3 and 4 occur 4 or 5 times during the night, and they are deep sleep. This is restorative sleep. Okay? Here are the substances that can significantly interfere with the ability to get in and stay in deep sleep. Alcohol destroys deep sleep. And tranquilizers also, prescription tranquilizers, reduce the amount of time spent in deep sleep. This is kind of counterintuitive because if people are experiencing enormous stress, they may have a few drinks and they say, that helps me go to sleep. Or they may take a sleeping pill, a prescription sleeping pill or a tranquilizer, and they'll say, this helps me go to sleep. But the problem is that daily use of these drugs in the long run often makes depression worse, largely in part because it reduces the amount of time in deep sleep. And finally is caffeine. And this is something that gets overlooked all the time. How much coffee, tea, Coke do you drink? And some of my patients said just 1 cup. Well, it depends on how big the cup is. Another thing you can find on this website is a caffeine questionnaire, which will allow you or your family member to determine the exact amount of caffeine that they're ingesting on a daily basis. Strongly recommend that everybody take the questionnaire. It takes 5 minutes to fill out, and you can determine the caffeine levels. This is the greatest negative impact of caffeine. It's not whether or not a person can go to sleep. Some people, if they have coffee in the afternoon or dinner, have trouble going to sleep. Of course, that can happen. But the biggest problem is that caffeine ingested in the afternoon or evening oftentimes makes it difficult for people to get into their first stage of deep sleep. And as you can see by the diagram here, that is the largest slice of deep sleep for the entire night. And so it's going to be important for depressed people to understand the reason for reducing caffeine is to directly have an impact on improving the quality of sleep. Sleep is so critical for emotional functioning that anything we can do to get rid of a sleep disorder or improve the quality of sleep is going to have a positive payoff. So for depression, really the goal should be 0 caffeine after noon. And for most people, they are able to then metabolize the caffeine that they have ingested in the morning time. And by night, the caffeine levels are low enough that they can go to sleep and also not have this interfere with deep sleep. Next is unaddressed psychological issues, and this probably is stating the obvious, but you can't fix everything with a pill. And yet many people do go to their primary care doctor because they have depressive symptoms. As I mentioned before, the majority of people in treatment are getting antidepressants. Sometimes that's very helpful, but let's say that the real issues are that they have a relationship problem where they feel disconnected from the person that they love, or they're facing enormous psychological stresses associated with a child who has a major medical illness, or their business is failing, things like that. Antidepressants could put a dent in these conditions, but obviously the real issue is that they have emotional and psychological challenges, and this is where psychotherapy is absolutely essential. Some of these causes are really clearly identified. For instance, if somebody loses their job. It's a real specific kind of life event, and in the wake of that, the person starts to become depressed. But it's very important to also note that sometimes the causes, the psychological causes of depression are they very gradually develop, okay? And let me give you two examples. One, I already mentioned briefly, is maybe a growing distance between two people in a relationship where it's been so gradual and subtle, hardly noticeable, but over a period of years, there's this kind of emotional wasteland, and people start becoming depressed, but it may be harder to put their finger on, why is it that I'm depressed? At some point, it starts to take a toll, and in psychotherapy, a part of what happens is to try to really take a close look at a person's life and determine what might be the cause. Another one would be the impact of aging, and looking at things like financial issues. It can be very challenging during older years, health problems, and so forth. And I've known a number of people that look forward to retirement, for instance, and yet they retire and they start to get terribly depressed because their life's not what they expected it to be. So we need to think outside the pill box. Oftentimes, people need psychotherapy. And then finally, our drugs that may cause depression, and here they are. Alcohol is clearly on the top of the list. And yet many people are suffering from anxiety and stress in general, but also from depression, and they're using alcohol to get some degree of relief. With depression, you take enough alcohol, it'll numb people from experiencing their feelings of depression. Also, it'll cause sedation, they can go to sleep, and so it certainly in the moment looks like the alcohol is helpful, but alcohol is the most potent drug that can actually cause or aggravate depression. Tranquilizers, steroids that are used for many medical conditions, some high blood pressure medications, especially clonidine and beta blockers. Many people are treated for high blood pressure, and after 2 or 3 months on some of these antihypertensive drugs, depression may occur. It affects about 7 or 8%. 7 or 8% of people that take these high blood pressure medications. And then finally, our female hormones, whether this be birth control pills or hormone replacement therapy, in some individuals can make depression worse. Okay, welcome back to part 3. And here we're going to talk about 5 must-do keys to success. In part 2, we talked about many problems that go unaddressed that account for poor outcomes. Now we're going to look at the things that are really essential for people to have a good shot at recovery from depression. Almost everyone who's depressed stops engaging in normal life activities. We already talked about that. In fact, one of the most effective treatments for depression is to get re-engaged with life. And one of the treatments that's used is called behavioral activation therapy. And in a nutshell, I want to tell you what this would involve. Let's say that we have a man and woman, a husband and wife, and let's say the gentleman for the last 3 months has been depressed. His wife comes in with him to see a physician or to see the psychotherapist, and they then ask the gentleman who's depressed if they have stopped doing certain things in their life that are customary and ordinary kinds of activities of daily life. And he might mention 1 or 2 things, but the wife is saying, but it's more than that, honey. Listen, you're not calling up your friends. You're not going to church. We're not going out to movies. We're not going out to eat at the restaurant. In other words, it's much more likely for a family member to be very keenly aware of how this person's life has become more and more narrow and cut off from normal life activities. Now, this may sound overly simplistic, but getting a calendar out, the therapist working with the couple, and writing down what the person normally would do prior to the time that they got depressed, and then have the wife become the coach and the person who really encourages her husband, we've got to do this stuff. Most people who are very depressed are not going to want to go out to eat dinner. And yet this, when this treatment works and is effective in getting people re-engaged with their life, it may be one of the most effective treatments for depression across the board. This is almost impossible to do for a depressed person on their own. They need support of a family member, possibly a therapist, to really get back on track with their life. Okay, exercise. As mentioned before, exercise is hard for people to get motivated to do in general, and especially when people are feeling depressed. How much exercise, though, can really make a difference? I think there are really 2 ways to look at this. The research on this shows that walking 10 minutes twice a day can help many people immediately feel a little bit better. Okay, this is sort of a quick fix. This is not something that's going to cure depression, but it can have an impact on reducing depressive feelings somewhat. Why this is important, I think, is that many times when people get so depressed they seek out treatment, they feel so pessimistic and hopeless that nothing's going to help me. And yet if they have somebody that goes with them on a 10-minute walk and they feel a little bit better, and they realize, you know what, that helped. That is something that sometimes can stir up a feeling of hopefulness that maybe treatment's going to work for them. There also are other treatments that involve more frequent and vigorous exercise that actually clearly treat depression. Skip over that. Get the best coach, best and cheapest coach, and it's a spouse, partner, or best friend. Now, one more thing I want to say about exercise is, although just walking can be somewhat helpful, the best results are seen with aerobic level exercise. The good news here is you don't have to be an athlete to do this. If a person is very fit, then that might be running or jogging or some similar sport. But if a person is not fit, it could be a brisk walk. But here's how you determine if a walk actually reaches a level that is aerobic. There's a certain threshold. If you really push yourself in walking, you start to cross where a person will notice they're starting to huff and puff. And that is a sign that this now has become aerobic level exercise. The other thing is, if you're walking with somebody, another way to determine if it's aerobic or not is when it becomes difficult to carry on a normal conversation with that person. So these are ways to determine whether it's aerobic or not. Number 3, antidepressants. If antidepressants are being used, it's important to know the following. Number 1, they are absolutely non-addictive. Many people make the mistake of thinking all psychiatric drugs are in the same class. There are some psychiatric drugs that can be addictive in certain individuals, like tranquilizers, for instance, but antidepressants are not. Secondly, unfortunately, currently available antidepressants are going to take generally 3 or 4 weeks, and sometimes longer, to begin to reduce depressive symptoms. And I'm going to tell you something, that is a long time for people to have to wait who are suffering with depression, but hanging in there can really pay off. Many people, after a week or 2, just give up, largely because they haven't realized any positive benefits yet. But also, again, we're talking about the pessimism that people experience when they're having depression. It's going to be important for the person taking an antidepressant to not be bashful at all about bringing up any issues regarding the antidepressants. Many people will run into a side effect, or they'll hear something on TV that concerns them about side effect problems with antidepressants, or it's not working right, it's not working as well enough, and a lot of people just, instead of talking about that, simply would just stop taking the medication. And as you know, the days of having a powerful physician say, here are 2 pills, call me in the morning if you need to, hopefully are coming to an end where people that are seeking out medical treatment as well as psychological treatment have a right to play an important role in the treatment itself. And this certainly means to be real above board about any problems that you run into with the medication treatment. All antidepressants are not the same. There are different classes, and many people take an antidepressant for maybe a couple of months at adequate doses, and maybe it helps somewhat, but is not enough. An option oftentimes is to combine antidepressants or go to a different class. So if the first antidepressant does not work for you or a family member, please keep in mind that there are really a number of other options. If you're thinking about stopping an antidepressant, it's important to talk to the person who is prescribing and really talk about the pros and cons. And a part of this has to do with your right to discontinue a medication. But 2 things. One, to evaluate, has it actually helped you some, and what the risks are of stopping. But the other is, some of the antidepressants, if you stop them cold turkey, people will experience withdrawal symptoms, which basically feel like you have the flu, nausea, achy, kind of just feeling sick. And so discussing discontinuation with your doctor is going to be very important. Finally, antidepressants can increase energy, enthusiasm, they can improve sleep, they can normalize appetite and reduce depressed mood to some degree, and for some individuals increase sex drive. But they don't mend broken hearts, they don't solve relationship problems, they don't eradicate grief. These are not panaceas. They're useful in treating some aspects of major depression, but obviously they're not going to address many psychological, emotional, and spiritual issues that go along with major depression. 4, this may sound like the obvious, okay, be kind to yourself, but here's the deal. When people are depressed, almost across the board, people become extremely self-critical, real harsh with themselves, real self-punitive. This is a time to, even if it feels like you got to push yourself to do it, to develop a sense of compassion for yourself as you're walking through this time of depression and beginning treatment. Strive for some balance in your life. When people are depressed, they go into survival mode. And oftentimes, it's about gritting your teeth and trying to get through the day. What happens in survival mode is people stop doing things that are self-nurturing. And this is something they enjoy, like going for a hike, going out to the movies, taking an evening and spending it relaxing in a bubble bath and listening to their favorite music and that kind of stuff. It may seem ridiculous to think somebody who has severe depression that doing these self-nurturing things will make a difference, but actually it does. It's about including some balance in a person's life. And finally, psychotherapy. And it's going to be important here, and once again, I'm going to probably be stating the obvious, but to find a therapist who really knows what they're doing. You have a right to talk to a therapist ahead of time on the phone and be real open with them and say, do you treat depression? And if so, what kind of training do you have? What kinds of approaches do you use? Most therapists will say, oh, I treat a lot of people with depression, but it's best to find people that have specific training in kinds of psychotherapies that have been shown to be effective in treating depression. Beyond that, if you go see a therapist, then you are basically doing like a job interview. And the first session, as you're talking about things, you'll also be checking that person out to see if you feel like they get it, that they really are understanding what you're saying. But very importantly also, how they come across as another human being who is, we want to look for somebody, we feel like this person has compassion, they really sincerely care about what's going on here, and they look like they're a decent person. That's going to be enormously important. And often, as this slide says, often depression can be challenging to treat. Sometimes you have to use a number of different approaches before achieving some success. Here's where it becomes really important to try to find a therapist or psychiatrist who is willing to say, no matter what, I'm not going to give up on you. If we run into roadblocks or certain treatments don't work or don't work well enough, then we're going to go to the next step and keep trying till we find a solution. This is a book. I'm one of the authors on this book, and this book, Make Every Session Count, is a guide to psychotherapy, and it's primarily for people that are in therapy or thinking about psychotherapy, about what do you do in therapy, what's it like, how can you make the most of a psychotherapy session, how do you find a good therapist, how do you deal with managed care companies to have them pay for psychotherapy and other psychiatric services and that sort of thing. This is a free book. It's a free download. You can go, again, on this website and simply access this book and see it on the screen of your computer or make a copy of that. A lot of people who have clinical depression will go for weeks and weeks, if not months and months, suffering. I've seen many people over the years that come in and they've been depressed for 6 months. And my question sometimes to them is, how come you didn't come in sooner? And there are really 2 reasons. One reason is people say, I thought I could get myself out of it. It's understandable that people certainly are going to be trying to do that on their own. But eventually they realize it's not working. But the other thing is that pretty soon into a depressive episode, people become so feel hopeless and pessimistic. They think nothing's going to help me. And yet depression is very treatable if it's treated by the appropriate kinds of integrated treatment that we've talked about in this video. And the most important thing for you or a family member to do right now is to take action and get in touch with a therapist, at least for one visit, to be evaluated to see if treatment, psychotherapy, or medications can be helpful for you. Thanks for watching.